Ingénierie ou du génie sanitaire dans le domaine du développement rural. Je voudrais demander à Monsieur Arjun Makhijnai de ce grand pays qu'est l'Inde d'apporter son expérience personnelle.
I wanted briefly to tell you about the health project I work for. I have only recently joined, but the project has been going on for about 2 years in some 30 villages south of Bombay. The basic idea of this project was to try and implement a barefoot doctor scheme under Indian conditions and to keep expenditures down so that it could be replicated in other areas and be within the means of the country, and to keep in mind that doctors who are product of our elitist medical colleges and institutions who do not want to go into villages will for some time at least be scarce in rural areas until we reform our education system. And also to organize the local communities so that the work that we might initiate would continue and be improved upon by the people for whom the system is designed and with whose help the system was designed. So basically, monies for this project were obtained from private sources, both in India and outside. They were not large, few tens of thousands of dollars have sufficed to carry us this far. And the village leaders in each village appointed one woman who was trained as a village health worker, only very briefly, 2 weeks or so. And one village health worker was appointed for about every 1,000 of the population. The function of this village health worker is primarily preventive care and health education. She is to visit each house at least once a month, find out if there are any people who might have persistent cough, refer them for TB examinations and screening, find out if any women have become pregnant in the last month, try and detect cases of malnutrition in among the children, and also to dispense simple medicines. Try and talk to the people, particularly to the woman, to the mother, and instruct her or chat with her about hygienic practices, cleanliness, and so on. For 1 in every 5,000 people, we have an auxiliary nurse midwife who really turned out to be the mainstay of the system. This system, as it turns out, is really in the field run completely by women. The auxiliary nurse midwife, also a woman, and all of the women who are working with us, there are 8 of them, were trained in a local college in a small town for a 1.5 years or so in the local language. And they're really extraordinary young women of 20 and 22 who cover 5-6 villages on a bicycle. They conduct enormous numbers of deliveries. They chase down TB patients who often don't come for treatment because they feel that they will suffer social sanctions if it becomes known, for example, that they have TB, or the parents are afraid that they won't be able to marry off their daughters. And similar taboos are present because of misunderstandings of the nature of leprosy. They also train the village health workers while they make the rounds of villages. They administer most of the drugs. And we also have a primary health unit where 2 doctors are stationed. One is a research doctor who designs the courses for these village health workers, in-service training for the nurses and village health workers. And we hold meetings of village health workers and nurses once or twice a month to check on progress, for records of each family, to see how they're kept, to see that deliveries are conducted in hygienic conditions, so the umbilical cord is cut with sterile instruments and not with any old thing, as is quite common in Indian villages, and therefore tetanus among little children and mothers also well, when I say common, I don't mean everybody has it, but it might be, 1 in 1,000 or 2 in 1,000. It's still quite high incidence. TB often has more than a 1% incidence. Apart from this, we've realized that the basic problems of preventive health really cannot be addressed without addressing the questions of water, sanitation, and food. And so we have recently begun what we call economic development projects that are based within the communities. We try and talk to the villagers to organize them, set up specific institutions within the village that will maintain these facilities, that will take up reforestation projects, that will supply fuel wood in an ecologically sound manner to the families, that will take up the projects of community latrines, maintaining them, composting the fecal material and then selling it as fertilizer and using the money for these latter projects have only recently been begun, and I don't have any reports, any substantial results to report on that. But during the 2 years that we've been there, we've had quite a lot of local support. We've become fixtures in the local scene now. And also in this case, because the Director of Public Health in our state is quite an enlightened man, we received a great deal of support from him, and half the medical staff is now paid by the state. The village health workers are paid by the village. They're not paid from the outside, although we contribute a small sum toward their salary, mostly paid by the village. And the government of the state has also become involved in the sense that they have adopted, at least tentatively, they've elected to adopt this particular scheme of healthcare, of reorganizing healthcare in India, on a pilot basis to cover about 2.5 million people in the state. And if that is successful, then it will be implemented in the whole state, which is bigger than most countries. It has a population of about 55 million people. What is the expenditure really that one incurs for such programs? The Indian government spends about 10 cents Canadian per capita on health, on rural health. Most of this goes into putting up the buildings and paying the doctors who don't work, in buying drugs which don't reach the poor people. And in some areas it's effective, but mostly it's been acknowledged by the government, by all private studies that have been done, that our medical and healthcare delivery systems have been a failure. What we have tried to do is two things. One, to reorganize it and introduce this element of what has been called public participation here, to give the term meaning, to have the people involved in the planning and in the implementation, to use as many people from from the villages themselves as possible, and also to increase the expenditures on the health system, because we are not putting enough money into our villages. Most of our money is going to the cities and the people who follow, which leads both to miserable cities and stagnating villages. The total expenditure that we incur per capita to provide this preventive and curative service, including deliveries, we don't cover all deliveries still by any means, is about 40 to 50 cents per capita per year. A sum that really any poor country can afford to spend, particularly if you look into the tremendous benefits involved. We hope for another $2 or so per capita per year that we will be able to accomplish providing clean water and sanitation, to really have a system that one might call a health care system that is managed and run and planned by local people. Thanks.
Notre ami indien est, comme vous le savez, peut-être ingénieur électricien. C'est assez curieux qu'on puisse parler de santé alors qu'on est ingénieur électricien et que l'on fasse avec autant de talent. Mais nous allons être encore plus étonnés car maintenant il va s'agir d'un architecte qui va nous parler d'un problème relatif au recyclage des gens âgés dans certaines conditions psychosociales très particulières vécues en France. Ce trait et ce passage